Buenos días. Vamos a darle paso al bloque de andrología. Tenemos a tres invitados en este panel. El primero es el Dr Ege Can Serefoglu, que viene de Uroclinic, del Centro de Medicina Sexual en Istambul, en Turquía, ex profesor de la Universidad Baxillar y un miembro muy activo de la Sociedad Internacional de Medicina Sexual, el ISSM. Luego viene la doctora Pilar Ceballos, que está uróloga, en este momento radicada en Canadá, va a hablarnos de disfunción sexual femenina, y finalmente vamos a tener a la doctora Mary Zamplaski hablando de infertilidad. Creo que ya no necesita presentación porque ya la teníamos anteriormente presentada. Vamos a darle paso al doctor Ege, que viene bastante lejos, para que nos hable un poco de sexualidad y diabetes. Muchas gracias, el doctor Serefoglu.
Good morning, dear ladies and gentlemen. It's a very big pleasure and honor to be here with our Colombian friends. I'm a urologist from Istanbul, Turkey. That's where I am from. This city is one of the oldest and most beautiful cities in the world. It has a lot of historical stuff, such as Hagia Sophia and many other historical places. This is Hagia Sophia. It used to be a mosque, it used to be a cathedral in the Byzantine era, but now it's a mosque. So this city combines many religions, many cultures, actually 2 continents. This bridge connects Asia to Europe. It's not only a historical and geographically important city, it's also a very young, very live, very vivid city with a beautiful nightlife. So if you ever come to Istanbul, please do not hesitate to let me know. Well, within the next 15 minutes, I would like to summarize the impact of diabetes on sexuality. After a brief introduction, I will talk about the impact of diabetes on men, which will be followed by the impact of diabetes on women, and finally I will give some take-home messages. Well, diabetes is a very common chronic disease that affects 0.5 to 2% of the world population. It causes complications through vascular, neurogenic, or psychological pathways, and it can also lead to sexual problems in both men and women. This is the map of diabetes all around the world, and according to the estimations, more than 371 million people have diabetes. The number of people with diabetes is increasing with the changes in our lifestyles and with the increased prevalence of obesity. Half of people with diabetes do not know they have it, and 80% of people with diabetes live in low and middle income countries. Half of people who die from diabetes are younger than 60 years of age. 4.8 million people died because of diabetes in 2012, and all those medical costs are exceeding almost $500 billion US. In this part of the world, in South and Central America, 1 in 11 adults has diabetes, and its prevalence is known as 9.2%, but we know that 45.5% of the diabetic population is undiagnosed. Let me take you to your med school years. This is the pathophysiology of diabetes. We have 2 types of diabetes. Type 1 is because of insufficient insulin in the body. Type 2 is the resistance to insulin. And in this figure, you can see the complications related to uncontrolled diabetes, retinopathy, nephropathy, peripheral neuropathy, which can also cause sexual problems, brain issues, cardiovascular problems, and sexual dysfunctions such as ED, ejaculatory dysfunction, hypogonadism, and female sexual problems. Let's start with men. The most important impact of diabetes is on erectile dysfunction, and diabetes is known as the most important risk factor for erectile dysfunction. Prevalence of ED in men with diabetes is between 35 to 70%, and this prevalence increases with age, duration of diabetes, and poor diabetic control. Today we know that compared to men without diabetes, diabetic men have 3 times greater risk for ED. They suffer from ED 10 to 15 years earlier. They suffer from more severe erectile dysfunction, and they have worse disease-specific health-related quality of life, and they are less responsive to the treatment options. In spite of these problems, 1 out of 8 diabetic men with ED is treated, so ED is a kind of neglected, underdiagnosed problem among men with diabetes. How does diabetes cause erectile dysfunction? Well, it's multifactorial. Hyperglycemia is associated with increased advanced glycated end products and oxidative stress. These result in molecular alterations such as inhibition of NO, macromolecular damage, protein oxidation modification, and endothelial apoptosis. All those molecular alterations results in cavernosal endothelial dysfunction and impair endothelial and smooth muscle relaxation, also cause hemodynamic alterations, and finally, the patient will come up with erectile dysfunction. The second pathophysiological mechanism is neuropathy, because somatic and autonomic neuropathies, which we encounter among diabetic population, also contribute to diabetic ED owing to decreased sensory impulses from the penis to the reflexogenic erectile center. Visceral adiposity, which may cause insulin resistance, and hypogonadism may also be other factors because in diabetics, testosterone concentration tend to decrease in association with low levels of LH and FSH. In addition to those mechanisms, comorbidities such as metabolic syndrome, hypertension, and smoking can also worsen erectile dysfunction in men with diabetes. But why diagnosing ED is so much important? Can't we just control the blood sugar levels of those patients and ignore erectile dysfunction? No, we cannot. At least we should not, because ED screening may identify underlying cavernosal coronary artery diseases. It may uncover diabetes, because we know that ED may be the first symptom in up to 20% of the diabetic population. ED screening may also detect dyslipidemia, and it may also reveal the presence of hypogonadism. In addition to that, we know that erectile dysfunction is associated with increased distress, depressive symptoms, decreased self-esteem, diminished quality of life, and marked effect on interpersonal relationship. So we should focus on the sexual complaints of every single diabetic man that we encounter with. How we should manage erectile dysfunction in diabetic men? Well, it's not that different from non-diabetic men. We have to start with a detailed medical psychological history and a focused physical examination. Patient and, if possible, partner education about their ED treatment should be performed, and patient follow-up and adequate exposure to the drug therapy is essential. This is from our European Association of Urology guidelines, and when we encounter a patient with ED plus diabetes mellitus, we have to take medical and psychosexual history. We need to identify sexual problems other than ED, such as hypogonadism or ejaculatory problems. We should identify common causes of ED. Identifying reversible risk factors for ED is the next step, and we should assess psychosocial status of the patient. Then we should perform focused physical examination, and finally, we should send our patient to the lab for glucose and lipid profile and total testosterone levels. We should not forget that diabetic population also uses many other medications, such as beta blockers, vasodilators, diuretics, and antidepressants, which may also contribute to the erectile dysfunction status. Okay, how we're gonna treat those people? Well, we should, at least theoretically, start with lifestyle changes and modification of the risk factors. We first tell our patient to control his blood glucose levels, and we can also advise him to stop smoking or excessive amount of alcohol consumption. We should advise him to lose some weight and do exercises. However, sadly, these lifestyle modifications do not really help in the majority of diabetic cases. Therefore, we have to talk with our patient and suggest some other medications, such as PDE5 inhibitors. But sadly, diabetics respond poorly to PDE5 inhibitors due to decreased NO activity and low testosterone levels. Then the patient will go other alternative treatments, such as intracavernosous injections. And if this fails, the patient will go eventually to penile prosthesis implantation. But don't forget that the risk of infection is much higher among diabetic population compared to non-diabetics. The second problem, hypogonadism. Well, 33% of men with diabetes have hypogonadism, and a significant amount of men with hypogonadism also suffer from diabetes. So apparently there's the kind of intersection between obesity, type 2 diabetes, and hypogonadism, and the exact mechanism is not known very well. But well-designed epidemiological studies demonstrated that when the testosterone levels go down, 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 first the patient complain about loss of libido, then the patient start to gain weight, he's gonna become obese, and then type 2 diabetes will develop, and ED will come next. In this figure, you can see the signs and symptoms of hypogonadism. So if a man with diabetes comes to your clinic with these complaints, you should diagnose hypogonadism. And don't forget that hypogonadism is associated with type 2 diabetes, and it may also result in reduced libido, testicular atrophy, decreased erectile function, difficulty achieving orgasm, and infertility. Several studies have demonstrated that hypogonadal men with diabetes can benefit from testosterone replacement therapy. It can improve erectile function, and also it can help you to control the glycemic status of the patient. Testosterone levels of diabetic men with hypogonadism symptoms must be evaluated, and testosterone replacement therapy should be initiated when necessary. But don't forget that there are safety concerns regarding testosterone replacement therapy, and hematological, cardiovascular, breast and prostatic assessments should be performed both before the initiation of the therapy and during the treatment. The last but not least, ejaculatory dysfunctions. These problems are known as the most common form of male sexual dysfunction, and ejaculatory dysfunctions are a kind of spectrum, starting from ejaculatory dysfunction, continuing with delayed ejaculation, and ending up with the complete absence of ejaculation, which is known as anejaculation. It also has retrograde and painful ejaculations. And diabetic neuropathy can deteriorate the nerves controlling ejaculation. Some studies have demonstrated the association between diabetes and ejaculatory dysfunction. Retrograde ejaculation was demonstrated in one-third of patients with diabetes. Exact prevalence is unknown. Erectile dysfunction in men with diabetes has been strongly associated with premature ejaculation. 40% of diabetic men had acquired PE, which was associated with the duration of disease and poor glycemic control. And many diabetic men experience delayed ejaculation due to peripheral neuropathy because, as I explained in erectile dysfunction, decreased sensory impulses from the penis to the reflexogenic ejaculation center may be responsible in delayed ejaculation. How are we going to treat those ejaculatory problems? Well, if the patient is suffering from retrograde ejaculation, you can try to give anticholinergics, antihistaminics, and alpha-adrenergics. If these treatments fail, recent studies demonstrated that volume-forming material of collagen injections into the bladder neck can be helpful. Diabetic patients with the complaint of delayed and/or retrograde ejaculation may benefit from ephedrine sulfate, pseudoephedrine, and imipramine. But these sympathomimetic agents should be used with caution in patients with cardiac disease, and they are contraindicated in hypertension, organic heart diseases, and arrhythmias. If premature ejaculation complaints are not alleviated after glycemic control, other PE therapies can be administered, such as topical anesthetics and daily and on-demand antidepressants. The last but not the least, female sexual dysfunction. It's much more complicated and much more neglected area of sexual medicine. Sexual function of women is associated with several physiologic events, including vaginal hemodynamics and lubrication, clitoral hemodynamics, pelvic and genital muscle activity, neurogenic innervation of the pelvic organs. And all these steps can be impaired among women with diabetes due to hyperglycemia, infections such as vaginitis, and vascular, neuronal, and physiological disorders. And as expected, loss of libido, decrease in arousal, decrease in lubrication, painful intercourse, and loss of orgasm are common among women with diabetes. But as I said, there are a limited number of studies. Female sexual dysfunction treatment requires a multidisciplinary approach with the participation of endocrinologists, gynecologists, urologists, and psychiatrists, and treatment options include lifestyle changes, weight control, treatment of diabetic complications, and treatment of depression. Medical treatments include systemic or vaginal estrogen applications. In addition to that, ospemifene is an FDA-approved agent for vaginal lubrication problems. It has positive effect on vaginal epithelium and minimal effects on endometrium. In addition to that, tibolone, phentolamine can be used for the treatment of lubrication problems. And lastly, there is a recently developed serotonin receptor 2A agonist and 2A antagonist, which is filibanserin. It has been recently approved by the FDA for the treatment of low sexual desire in women, and future clinical data are necessary to elucidate the efficacy and safety of this molecule. So in conclusion, diabetes is a common and important health problem. Diabetes has detrimental effects on the sexual function of patients, and these effects can be ameliorated with a multidisciplinary approach. ED is common among men with diabetes, and hypogonadism is also common among diabetic men. Ejaculatory dysfunction is the most common form of male sexual dysfunction, and it can be seen among men with diabetes due to mainly neuropathies. And diabetic women can also suffer from female sexual dysfunction. Most importantly, diabetologists should not only focus on the glycemic control of their patients, they should also address their sexual complaints, because these problems can really significantly impair the quality of life of their patients. Thank you so much for your patience.